Hello, everyone. I'm Neal Shore. I'm a urologist in South Carolina, and it's a great pleasure on behalf of eCancer to have a conversation with my dear friend and colleague, internationally renowned professor of medical oncology at Tulane Medical Center, Oliver Sartor. Let's just take a few minutes and highlight some of the really more interesting abstracts and podium and plenary presentations at ASCO 2021 this year. So Oliver, what a great year in 2020. Despite the pandemic, we saw the approval of two PARP inhibitors in the US and in other countries for our mCRPC patients in the forms of olaparib and rucaparib. But there are other PARPs that are being evaluated, and we're trying to get a better understanding with what's the implication based upon specific gene alterations. What about combining PARPs with other approved therapies? So let's just first talk about this abstract by Tim Reason et al., the indirect treatment comparison of the efficacy of olaparib and cabazitaxel in their approved dosing and formulations for patients with mCRPC. And this really came from the PROfound trial. And this was sort of an indirect comparison to see how did the patients who had BRCA mutations do vis-a-vis their exposure to cabazitaxel or getting olaparib. And similarly, they looked at patients who had ATM. Your thoughts on this presentation, and even your real-world experience with both BRCA patients and ATM patients?
Thank you, Neal, and thank you for the introduction. So, first of all, these are both good agents. We're talking about olaparib. We're talking about a really nice PARP inhibitor with excellent data, published in the New England Journal, survival benefit despite the crossover. And with cabazitaxel, we also have an excellent agent, second-line taxane, and one that has unequivocal utility. Now, what I think is interesting here is that we focus a bit on these different mutations, the BRCA and the ATM. And one of the things that came from this particular abstract is that the BRCA mutations appear to benefit from the use of the olaparib. And the ATM, well, I'll just simply say it's a little more of a wash, but maybe favoring the cabazitaxel a little bit. So when we think about the PARP inhibitors, we have to think about the variety of homologous recombination repair defects, not just the BRCA, but also the rest of the story. And keep in mind that, in my opinion, all patients should try to receive as many therapies as possible that are known to be life-prolonging, because that's really where we can benefit our patients most, by ensuring that our patients get the most therapies. But in this case, BRCA in particular, think about the olaparib, because that's a really, really good drug in that setting.
Yeah, great points. And of course, you have to test in order to find out if patients have an HRR mutation. And then there are some other ATM-specific trials that are ongoing. So none really reported out yet. I know you and I are both involved in some of those. So it's a very interesting additional specific pathway for those patients. Here's another interesting abstract presented by Mera et al. And this was really looking at yet another potential PARP inhibitor known as Talizoporiv. And this is the reports really mostly on the detailed safety analysis in this phase 1 study, again, looking at patients with mCRPC. And of course, if we have a third PARP inhibitor in prostate cancer, and potentially even a fourth PARP inhibitor, niraparib, the question will be, will there be any sort of differentiation in tolerability and safety? Here, the authors are clearly reporting on a good tolerability and safety in heavily pretreated patients. But Oliver, where do you think this is going to land? That's always something that we tend to look about when we have many different, yet similar mechanisms of action, drugs in a class, but can there be differentiation in tolerability and safety?
Yeah, so it's an interesting compound with talazoparib. So when we go to the PARP inhibitors, we say that they're similar, but there's a PARP trapping mechanism that has been linked in some of the basic science studies to efficacy. And it turns out that talazoparib is really good at this PARP trapping mechanism, to a greater extent perhaps than the olaparibs and rucaparibs of the world. So when we look to the efficacy data, the first thing I'm going to say is we really don't have enough efficacy data, but there's some pretty high hopes for this compound. In terms of the safety, I think it reasonably well tolerated. I think it fits into the PARP inhibitors with regard to the type of anemias and a little bit of thrombocytopenia, tiny bit of neutropenia that we might see with this class of agents, some GI side effects. I don't think the side effect profile is going to be particularly distinguishing, but I really want more efficacy data with talazoparib, and I do look forward to seeing it because it could be a little bit distinct.
Yeah, no, I agree. And of course, the heterogeneity of the patient population is always sort of interesting to see if maybe one is tolerated versus another one not being, but we don't really have those prospective comparator trials yet. Here's an interesting abstract by Su et al. It's a differential responses to taxanes and PARP inhibitors in both ATM and BRCA patients. And once again, I think it's fair to say, much like some of the earlier presentations, we see better outcomes in the patients who are BRCA2 especially mutated as opposed to ATM. And that may have implications on how we sequence taxanes. Any additional thoughts on that, or how you discuss this with your patients in clinic?
Well, it is interesting, and it sort of reiterates some of the thoughts we had a little bit earlier. You know, within the olaparib phase 3 trial, the so-called profound trial, it was an interesting element looking at the ATM subset. And it appeared as though if those who had taxanes first and then the olaparib second probably did better for the ATM mutated as opposed to the inverse mutation. So remember within the profound study that there was a stratification. Everybody had to have a novel androgen axis agent such as abiraterone or enzalutamide, but not everybody was required to have the taxane. That was a stratified analysis. For the BRCA patients, giving that olaparib for the BRCA, particularly the BRCA2 patients, probably in their best interest, doing it early. But maybe for the ATM, we use the taxane first, and then we use the PARP inhibitor second. Getting back to the differential effectiveness as classified by the individual gene defects, that I think is going to dominate some of this next level of the PARP discussion. By the way, PALB2 is another one that appears to be quite PARP active, and BRCA1 may be a little less than BRCA2. BRCA2 is kind of the king. That's where the best responses are.
So here's a follow-up trial, Oliver, from the ACIS study. I was fortunate to be part of this. Dana Rathkopf presented the primary and secondary endpoints of RPFS and OS at ASCO GU 2021. And here's a follow-up presented by Saad et al. And essentially, they looked at two subgroups, looking at patients who had visceral disease as well as patients over 75. Basically another way of thinking of these patients who are at most at risk, and not unreasonable to stratify for them. And they clearly saw some improvement in these patients who had the combined ABI-APA as opposed to just receiving abiraterone alone. But what are your thoughts about this combination and where it's going to go into the future?
Yeah, great question, Neal. One of the problems I think is that there's really not been a commitment from the sponsor to be able to move this combination forward. When the RPFS hit, initially it looked pretty well in the overall ACIS trial. And here we have a subset analysis demonstrating that there's benefit within a group of hard to treat patients, particularly the visceral metastases. But, I don't see this as a big enough need that we're going to be able to use this as a standard of care. So even though the trial is positive from RPFS, the OS is not particularly positive. In fact, it's not positive at all. And I think that's going to inhibit the development of this combination.
Yeah, I agree. But yeah, of course, these hard to treat patients, elderly and visceral metastasis, it is an interesting finding. Now let's go to the next one. This is by Lopez Campos and his co-authors, evaluation of PSA progression, sort of an opportunity looking at real world data. And, interesting, they looked at PSA progressions at 4 weeks, 8 weeks, 12 weeks. Not excessively novel, and that clearly we've been looking at, the PSA kinetics and castration sensitive and castration resistant. and that's where PSA does ultimately show to be a good indicator of disease progression. Their conclusions at 4 weeks with Enza and Abby, if there was progression, you would expect, and it's both predictive and prognostic. How do you look at this data, Oliver, and and teach our colleagues, residents, and fellows about monitoring PSA in conjunction with all other serologic parameters?
Yeah, good question, Neal. One of the things that I think is sort of intuitively obvious is that up is bad and down is good. And we have a couple of therapies out there where PSA responsiveness, such as sickle cell T, such as the radium-223, where the PSA and the overall survival is a bit delinked. But these are hormonal agents. And with hormonal agents, if you don't drop the PSA, you're not having an effect. And early progression translates into worse results. So what we really conclude here is that early progression is bad progression. And that's not at all surprising when you use a hormonal agent, because here the PSA is really an indirect marker of that AR axis inhibition. So early progression is worse. I'm not sure that I am particularly surprised by that conclusion, but here's more data to suggest that it's true.
Yeah. Thanks. And we got a couple more. And how about this TalaPro 2 study? Full stop. I'm part of it, so don't say anything too negative. We're a study in progress. It's an interesting use of combining another PARP inhibitor approved. Talizoporiv is approved in breast cancer, not yet in prostate, but combining it with enzalutamide. There's other studies looking at PARP inhibitors, combining them with abiraterone. And then, of course, what's interesting about this study, it was an all-comers right now, and we're still collecting our data and accruing, but looking at both the DDR positive and the non-DDR positive, and maybe there's some synergy, getting back to your commentary earlier about enhancing BRCA-ness. If you would comment on this, and just the whole field of combining PARP inhibitors now, it's really opened up a lot of interesting trials.
It's a very important study, Neal. We have some provocative preliminary information that inhibiting androgen axis and being able to inhibit PARP may have some combination effects that would be independent of what you might expect for either agent alone. Here you have a very good PARP inhibitor. You have a very good androgen axis inhibiting agent. You put them together in this all-comer scenario. And of course, we don't really know what's going to come out, but I'll tell you what I do know. I know that I'm interested in the results. If this trial is positive, it could be a game changer. Now, that's a big if, because we don't have precedent in a large phase 3, but we do have some preliminary positive data, and that's from other agents in other trials. Nevertheless, important trial. I'm keeping a close eye on it, and really look forward to being able to see what the results show.
Yeah, thank you. And let's conclude with arguably, which could and should be the most significant presentation at ASCO 2021 this year. And I say that with great respect for the enormity of the wonderful work by our colleagues, but this is the VISION trial that you've been the co-PI on with Mike Morris. And what an important study, the first phase 3 trial to look at a theranostic and the results, which are clearly positive, and how this is going to change the treatment discussion and the therapeutic landscape in mCRPC, and maybe even at some point in mCSPC. So I'd love to hear your commentary on the presentation on the RPFS and OS.
Yeah, first of all, just a minor correction, if you will, Neal. My co-PI on this was Bernd Kraus from Germany. So it turns out that Bernd and I were actually the co-PIs. Mike was chairman of the steering committee, but just to be able to get the allocation right, because Bernd Kraus might be listening, I want to make sure he gets the credit too.
Absolutely.
Yeah, so bottom line is these are very difficult to treat patients, first of all. These patients had all failed abiraterone or enzalutamide, that all failed 1 or 2 taxanes. And in terms of the cabazitaxel, which is an important discussion point here, 38% of the patients had already been receiving and failed cabazitaxel. very, very difficult to treat patients here. So the design was basically to take this difficult to treat patient, do a PSMA scan, and try to figure out who was going to have a positive PSMA lesion on PET. And the answer is about 87% of the patients had a definition that led to PSMA positivity, and that was uptake greater than the liver and at least one metastatic lesion. In addition, because you can have large lesions that are PSMA negative, we wanted to exclude those patients. We excluded some of those. But bottom line is 87% of the patients we PSMA scanned were positive. Prospective randomized trial, overall survival and RPFS as the two endpoints. Both endpoints are strikingly positive with the PSMA lutetium-177, and it's a very specific PSMA molecules, PSMA 617. And so this trial showed an overall survival benefit hazard ratio of 0.62. When we look at the RPFS, positive at 0.4, blazingly positive, well tolerated as well. There were a few more of the AE grade 3s, but on the other hand, it typically was well tolerated, and we also built in quality of life. The quality of life was better as well on this treatment. Living longer and living better as part of this trial. It is a game changer. I anticipate it will receive regulatory approval whenever those regulatory documents are presented throughout the world. This is going to be a new treatment for prostate cancer in very difficult to treat patients.
Well, that's fantastic. And, I was proud to be part of this study. It's a great study. Congratulations to you and all the folks who were involved in this. This is a game changer. We use that word sometimes, glibly, but no, not here. This is really going to open up so many other opportunities for theranostics, working more hand in glove with our nuclear medicine radiologists, and even thinking now in potential other trial opportunities, pre-chemotherapy, and even earlier in the disease state. So what a great way to end, a great way to have a super interesting and provocative findings for ASCO 2021. Oliver, thank you so much for your insights and your expertise. And again, thank the folks from eCancer for allowing us this opportunity to speak with you.
Thank you, Neal.